Hey everyone, let's jump right into this explainer and explore the fascinating microscopic plumbing of the human kidney. It's honestly a complete marvel of human physiology. We're going to discover exactly how specific medications can act like tiny little stoplights inside your organs to perfectly manipulate your body's fluid balance. Now, the foundational secret to how all this works comes down to a really important concept called natriuresis. That's just a fancy term for the excretion of sodium and water in your urine. You see, by forcing sodium out of the body, water inherently follows right behind it. And that right there is the secret to how all diuretics relieve fluid overload, whether we're talking about a slightly swollen ankle or a completely life-threatening case of pulmonary edema. So here's our roadmap for the journey. We're going to unlock the kidney's floodgates, check out carbonic anhydrase inhibitors, then dive into the sheer power of loop diuretics, thiazides, and potassium-sparing diuretics, before finally putting it all together to build a complete diuretic regimen. All right, Section 1, Unlocking the Kidney's Floodgates. Before we can actually talk about the drugs themselves, we really need to understand the physical structure where all this microscopic magic happens. We're looking at 4 distinct locations inside the nephron, which is the basic functional unit of the kidney. We've got the proximal convoluted tubule, the loop of Henle, the early distal convoluted tubule, and the cortical collecting duct. I want you to think of these as 4 unique toll booths where our medications can block sodium from being reabsorbed back into the blood, effectively trapping it in the fluid that will eventually become your urine. Moving right along to Section 2, carbonic anhydrase inhibitors. So our very first stop on this river of filtrate is right at the beginning, the proximal convoluted tubule. And the flagship drug that targets this specific area is called acetazolamide. What's really fascinating here is exactly how acetazolamide works. It blocks an enzyme known as carbonic anhydrase. By blocking this, we intentionally force bicarbonate into the urine. Now, because bicarbonate is basic, losing it actually lowers your blood pH. And while that sounds like a bad side effect, it's actually incredibly useful for treating the respiratory alkalosis you get with altitude sickness. Basically, when you breathe way too fast climbing a mountain and your blood gets too alkaline, this drug restores the balance. Pretty cool, right? It also decreases the production of certain fluids in the eyes and brain, making it absolutely vital for treating glaucoma and idiopathic intracranial hypertension. Okay, Section 3, the power of loop diuretics. As we move further down the nephron into the thick ascending limb, we encounter the true heavy lifters of volume management, and it starts with a massively powerful drug, furosemide. If we block the specific gate right here, which is the sodium-potassium 2-chloride cotransporter, a tremendous amount of sodium just stays in the tube. And remember our rule, where sodium goes, water heavily follows. This gives us our absolute first-line defense for a hypervolemic patient who, frankly, looks like the Michelin Man due to congestive heart failure or pulmonary edema. But, this extreme fluid removal definitely comes with risks. As all that filtrate rushes past the later segments of the kidney, it literally washes out potassium and protons like a river, leading to hypokalemia and metabolic alkalosis. It also forces the body to just dump calcium and magnesium into the urine, and, crazy enough, at very high doses, it even carries a risk of hearing damage. To really understand just how incredibly potent these drugs are, there's a fascinating 40-21 clinical ratio. Just 40 milligrams of furosemide packs the exact same diuretic punch as 20 milligrams of torsemide or a mere 1 single milligram of bumetanide. It's wildly powerful stuff. Let's hit Section 4, thiazides and calcium conservation. So as that remaining fluid enters the next section of tubing, the early distal convoluted tubule, we use thiazides. A great example is hydrochlorothiazide, and we use it to block the sodium chloride cotransporter. Now, here is where we see an incredible localized shift in the body. It's a huge contrast to remember. While loop diuretics just dump calcium into the urine, thiazides actually stimulate calcium reabsorption. They conserve it right there in the bloodstream. Because thiazides conserve calcium while causing a steady, moderate loss of sodium, they are uniquely perfect for some very specific scenarios. For instance, they're a frontline choice for treating essential hypertension. Plus, if you have a patient suffering from recurrent calcium kidney stones or even osteoporosis, thiazides are literally ideal because they pull that calcium out of the urine and lock it back inside the body. You do have to keep a close eye out for complications, though, like hyponatremia from losing too much sodium, hypokalemia, hypercalcemia, and sometimes even an increased risk of gout. All right, Section 5, Potassium-Sparing Diuretics. We have finally made it to the very end of our anatomical journey. Down at the late distal tubule and the cortical collecting duct, flagship drugs like spironolactone and amiloride act as the final bouncers at the door before that fluid officially becomes urine. Now, these drugs are really unique. Spironolactone is an aldosterone antagonist. That means it completely blocks the hormone that normally commands your body to hoard sodium and dump potassium. Amiloride, on the other hand, directly blocks the sodium channels. But by blocking aldosterone's effects, these medications uniquely prevent the potassium dumping that we see in almost all the other diuretics. And because of this potassium-saving superpower, they're life-saving add-ons that actually reduce mortality for patients dealing with heart failure and cirrhosis. The main things you have to watch out for are retaining too much potassium, which is hyperkalemia, and with spironolactone, it can occasionally cause gynecomastia because of how it interacts with steroid receptors. Which brings us to Section 6, Building a Diuretic Regimen. Okay, now that we've visited literally every toll booth in the nephron, it's time to put on our clinician hats and see how these tools are actually combined. You always want to tailor the regimen based on the patient's exact fluid status, and the absolute best way to monitor that is through strict daily weights. When you need heavy fluid removal, you always start with a loop diuretic. But the body is smart, it fights back. So if sodium spikes while using a loop, you just add a thiazide. If potassium crashes, well, you add a potassium-sparing diuretic. It is all about finding that exact perfect balance. The really crucial point here is seeing how beautifully these drugs contrast with one another. Let's say a loop diuretic is doing its job perfectly, but it's causing metabolic alkalosis and hypokalemia. Well, you can simply reverse engineer the problem. You just add a drug like acetazolamide or a potassium-sparing diuretic to push the pH and the potassium right back the other way, completely restoring harmony to the patient's blood chemistry. It's exactly like mixing tracks on a soundboard to get the perfect output. And all of this brings us to one final, completely mind-blowing thought. How does manipulating just one microscopic ion channel cascade into full-body hemodynamic shifts? When you really sit back and realize that blocking a single cellular gate can literally cure heart failure or save someone from dying of altitude sickness, it totally begs the question, what other microscopic switches are hiding inside our physiology, just waiting to be unlocked? Thanks so much for joining me on this explainer. Keep asking questions, and I'll catch you on the next one.